This is an excerpt of a webinar by Garrison Dental. Thank you to Garrison Dental for allowing us to post this excerpt. To see the full-length version, please contact www.garrisondental.com. All opinions are those of Straightsmile Solutions. We are an orthodontic consultancy company that helps general and pediatric dentists with their ortho cases and education. For help with a case, please visit www.straightsmilesolutions.com. Now, enjoy the show.
Unless you understand what it takes to be successful in aligners, you're not going to be successful. And there's a lot of variables. And I find a lot of doctors do some things right and a lot of things they don't understand what they're doing wrong. So the first thing is going to be case selection. And that is something, obviously, as an orthodontist, I'm great at case selection. For me, there's never a no for aligners. Everyone's an aligner candidate. Because I've mastered aligners. As a matter of fact, I've never said no to an aligner case. It might be a situation where there's a case that might be more efficient with braces or another way, but we can still do it, A long time ago, I used to say no all the time, but now I don't. Everyone's an aligner candidate, right? You want it. Matter of fact, we've gotten to the point in our practice, my husband has a practice, and soon we're gonna have a few more practices where everything's aligners and removables. There's no fixed at all. So, and we feel very confident with our skills. But you as a new, orthodontic provider may not have that skill set. So I really, really recommend the first maybe couple hundred cases that you bounce them off an orthodontist. Doesn't have to be me, can be anyone. There's lots of orthodontists that will help you, and not many will do it at no charge. Especially if you're a good referrer to the orthodontist, it's really worth an ask to talk to your local orthodontist in your community and say, hey, I really want to get started. I want to start doing better ortho. Not everyone always wants to refer out. I'm still going to refer you out, as needed for certain types of cases, but would you be willing to sit down and have a study session with me so I can go over a few cases? They might say no, but they might say yes. And as my auntie always said, don't ask, don't get. So you might as well ask, right? But there's, support your local orthodontist first. If they say no and you still want help, there's a lot of orthodontists out there that are hurting right now because as ortho has changed, over the last 20 years, we don't quite make what we used to, or not even close. So, support the orthodontist in their community. Second one would be design and treatment plan. Again, this is something that you can learn over time. You always want to have an independent person who doesn't work for that company to help you with the design and treatment plan. Now, I've worked with Invisalign Pro. Sometimes it's good, sometimes it's bad. So it's terrible sometimes, and you won't know. So that's why I like the idea of having an independent person who has a similar philosophy as you to help you with your designs and treatment plans. They should be a licensed orthodontist in the US though. There's a big difference in quality. And like I said, I've worked with a lot of people. So that would be my suggestion. Third would be production, of course. You shouldn't have any production issues if it's Invisalign, ClearCorrect, SureSmile, Reveal, major brand companies. It's all been really good. I mean, very rarely are you gonna have a one-off manufacturing warranty issue. I very, very, very rarely see it. So it used to be an issue maybe like 15 years ago. If you're making in-house, that's a whole totally different story. We'll kind of lightly touch about the white label in-house fad phenomenon. We do that in our office. We don't, space is really expensive in Hawaii, so we don't have our own lab. So we outsource the manufacturing. We do this on simple cases. So we use Invisalign, and like I said, I'm not going to promote any products, but that's what we chose to use just because we feel comfortable with it. There's a lot of different reasons. Nothing wrong. I've used ClearCorrect before. I'm fine with that too, just maybe not for me. But we also do white label where we outsource all the production to a local lab. It's a little clunky. It can be, you have to really be on it with the organization. There's no good dashboard. There's a lot of negatives to it, but it's crazy cheap, okay? Like crazy, crazy, crazy cheap. As low as $99 for the setup, decent treatment plans, and $20 per aligner. And this is only in the US. I don't know what's available in other countries. So it's pretty smooth in the US. So again, happy to make intros if you'd like to meet. There are a lot of great white label design companies that are out there that are all US based. The ones I work with are only US based, and I feel comfortable with them. I have about 3 that I work with. So I'm glad to introduce you. If you want to reach out to me, there's no deadline on the introduction, of course, because that's just an intro. And lastly would be compliance. And compliance is something that, again, orthodontists are great at and general dentists are not so great at. And as a mom, I'm pretty on it with compliance, but You have to have a compliance program. You have to have an accountability loop. There's a lot of things, and that's going to be my last slide, and we'll definitely go into that. But if you don't do this, I mean, you're never going to finish cases. You know, they're just going to spin in circles, basically. And speaking of compliance, you should know your revision refinement rate. If you do not know your revision refinement rate, like what is your frequency of refinements? In our office, it's pretty low, like way less than 30%. And when it's just me practicing, it's like 5%. Because I nail my treatment plans the first time and I'm on it with compliance. I use virtual accountability loops and a lot of different stuff. But the average rate is much higher. I mean, if I had to guess, and Invisalign doesn't really publish the rate, although there's a way you can ask them about your analytics on that. So you should reach out to your TM about that. If your rate is more than 50%, you are doing something wrong. And you should definitely fix that because, you know, patients aren't going to be happy. You're not going to be happy. Your staff's not happy. No one's loving it. But if you can, what if I told you you could do an aligner case in just 3 visits? Well, most orthodontists do that I know. First visit is going to be the records and the scan. This is assuming you're doing a scan. Second visit is going to be delivery attachments and IPR, and we're going to get into IPR later, of course. And third visit is going to be debond. We're then deliver retainers. That's it. Super, super, super easy. You know how profitable that is? It's crazy profitable. And the cool thing about aligners is that pretty much your team or staff can run the whole show. You as the doctor, you're the brain of the operation. You're just doing this puzzle, creating this cool plan. It's so fun. I love puzzles. But that's all you have to do. Everything else can be done by your staff. And you know, I'm not going to go into the whole like practice limitations and things like that. You know, in California, depends. I mean, and RDAEF can do certain things. They can put on the attachments. It's a bit of a gray area, so I'm not even going to it. But most doctors have their assistants do everything except for the IPR. Obviously, IPR has to be done by the doctor, as far as I know, in every state. And the debond. Oh no, some states the RDAEF or the hygienist can do the debond. But in any case, pretty easy stuff. Fun. Okay, so before we get into we haven't even gotten to our 12 tricks and tips yet. And I don't know if I mentioned, this is going to be like a solid hour. Usually this presentation takes me 2, and I'm going to talk crazy fast because it is late. So that's why I want to extend those additional resources to you if you want to learn more, because I have tons more information. This is a crazy abbreviated version. At the end of the hour, we will show the code. Y'all can jump off if you want to jump off. Go enjoy your night, go to sleep, have a beer. Those of you who want to ask questions, we will stay on another 10 minutes or so for questions after we give the code. But before we get started, we need to get oriented. We need to make sure you're thinking the way I'm thinking, you're speaking the way I'm speaking. Let's talk about different ways to move teeth. And in my world, there's 5 different ways to move teeth. And most general dentists are only familiar with a few, usually not all 5. So I'm going to kind of take you through the most simple to the most difficult. Well, maybe not. But okay, so let's get started. And I can't see myself, so I'm going to try to center. I have some like things to show you. I'm going to try to center them in front of my face because I know you can see my face. So hopefully this works. I like demos. So the first one, okay, let's do this. The first one is going to be arch expansion. I know you know about this. So arch expansion is taking an arch where somebody's crowded, right? And widening it. If I widen the arch, I get more space, right? Easy. So it's kind of like an arch wire here. This is a typical arch wire in braces. This is the arch form. Let's say it's like narrow. I make it wider. Everything that's crowded now has space to straighten up. We call this an occlusogram, how we measure it in ortho. But anyway, so simple. I think you get that. All aligner companies, even direct to consumer, do arch expansion, okay? Mostly it's okay, but it's not always okay. So certain patients I don't want to do arch expansion on. And remember, whenever you're doing an aligner treatment plan, we talked about optimizing the treatment plan to get best results. You need to know, is it okay for me to do this? I can't always tell you. There's a lot of things. A lot of this is clinical. We're looking at the bones. We're looking at the root. We're looking at the root scalloping. We're looking at the periodontal conditions. We're looking at the perioprobings. So a lot of things you need to think about in making that decision. If I have a perio patient, I do not do this. Nope. I just say in the treatment plan, no arch expansion. That's it. Or I say only 1 millimeter of arch expansion. The defaults in ClearCorrect are well over 2 millimeters. Invisalign has 2 different defaults. When you go into your preferences, you can set it for less or more, depending on what you do. Mine set is more, but I just undo it when I don't want arch expansion. So healthy young patients, great. Unhealthy older patients, no. Okay, easy to remember. When in doubt, don't expand arches, because you can push the teeth through the bone and devitalize them, and you can lose a lot of teeth. And I've seen it happen. It's not good. Okay, number 2 is going to be proclination. And proclination, again, done in all aligner companies as well as direct to consumer. Proclination means flaring or proclining or tipping the teeth forward to get space. Again, okay in healthy patients, not okay in unhealthy patients. As an orthodontist, most of the time I am taking Ceph x-rays, and I love Cephs just because I can look at a Ceph, I don't even have to get the numbers, and I can tell you exactly what's going on, what I should do, what I can't do, at least in terms of vertical stuff, okay? AP or sagittal stuff, so that means backwards to forwards, like this direction, vertical this direction. Can't see transverse in a Ceph, it's a lateral Ceph. But there's a lot of things. So obviously, for example, this Ceph, I mean, my eye's trained to do this. So there are, and a lot of general dentists get freaked out on Cephs. And I'm not even gonna go into the do you need a Ceph, do you not need a Ceph, because obviously Invisalign doesn't require Cephs, ClearCorrect doesn't require Cephs. I love them because it tells me what to do. I don't like to guess. So I take them, you don't have to take them. When I work with my private consulting patients, sometimes if you've worked with me, I'm gonna say, I'm sorry, I can't tell you without a Ceph. I mean, this is just too big of a decision. I would need to see the Ceph. I'm not sure. You know, it's kind of like guessing without a roadmap. So Cephs are really, really, really useful. You can take a Ceph slice on a CBCT. A lot of doctors I know do it. You're gonna need to talk to them about how to do it because every setting is different. And it's a lot of just like practicing to get the slice. In terms of numbers, there's a lot of places you can send it off. I do have a Ceph playlist. I'm glad to share that with you, everything that I know so far. Again, reach out to me if you want a copy of that. But they're very useful. But yeah, that if I know whether or not I'm gonna procline or not, sometimes I'm looking at the anatomy of the teeth, sometimes I'm looking at the root scalloping, looking at the bite. There's a lot of things that go into that decision on whether or not I can procline teeth or not. Okay, so that was 2. We said there was 5, right? Number 3 is going to be IPR. And obviously I like IPR because I'm here, and Garrison is, in my opinion, the best IPR company to buy, and we'll go over their product. And that's part of the reason I started lecturing for them, is because I started using their product and it was just second to none, and it's what we totally use in our office. So, and I'll explain the why behind that. Definitely want to sign up for our IPR webinar. It's going to be awesome, May 17th. But yes, IPR, if it's done accurately, is awesome. You can remove up to 5.5 millimeters of tooth structure per arch. That's going to give you a lot more space to straighten things up, and it's especially great on perio patients. I don't normally do it on kids, so it's usually for older patients because kids can get sensitive with IPR. So I just don't do it on kids. You know, I find other ways to do things. What else? Okay, next one is one you've probably never heard of, and it's called distalization. Okay. So distalization means, let me see what I've got for a demo here. We'll look on my typing on. Okay. That means scooting. Sequential distalization means scooting teeth one tooth at a time backwards. And I know I talked about forwards orthodontics, and that's mostly what I'm pro. But sometimes, you know, if we don't want to take out teeth, there's limited options, right? Or sometimes maybe the teeth are crazy flared. We see it in the Ceph and we want to tuck them back a little bit. So you can do this, I think, on most aligner companies and some of the direct-to-consumer companies. It's an option, but you have to ask for it. It will never, ever be the default. You will never get it in your treatment plan unless you ask. So that's just one of those things, little tip. Ask for sequential distalization, but the trick is you have to check the pano. For example, on this case right here, cannot do it. Why? We've got 1 and 16, or upper 8s are impacted. Obviously, they're right at the height of contour. Not gonna happen. Can't scoot, you know, the upper 7s or the second molars back so that we can scoot the next one back, so that we can scoot the next one back, because it's gonna run into it and damage the teeth. It's just not gonna happen. So if you ask for it, they're assuming you have your 3rd molars out. You can do it on the top or the bottom. On the bottom, you can do less. I can usually get up to about 1 millimeter and a half. On the top, I've done up to 5, 6 millimeters. I can do a lot, but you have to check the bone too. There's a lot of things you need to check. So like, for example, in this picture here, can't do it here, but assuming there's nothing impacted, we have some ridge there, can do it here. So you have to ask for it, and it takes time. This is not something, and it's not offered in the Express or the Light or anything like that. It's not offered. You need to do comprehensive to do it. So sequential distalization, my daughter gave me this demo because I'm always looking for visuals. I'm a visual person, is scooting each tooth 1 tooth at a time. It takes time. You are not going to finish this case in less than 50 aligners. It's going to take time. It's not a quick fix, okay? So just keep that in mind, but it's really, really great. You don't have to do IPR if you don't want to do, you don't have to wear elastics, and you get a really nice outcome. Cool, cool trick, right? And lastly, we have our extractions. So lower incisor extractions, fine, great, I'm cool with that, especially perio patients or slight class 3 edge-to-edge patients. Premolar extractions, not my thing. I'm not saying I don't do them. It is always, always, always last resort for me. I'm like, I have no other options, you know, for whatever reason. So do I do it? Yes. Very, very, very rarely. But I was trained to do it all the time. So, you know, and I'm always untraining doctors, you know, please don't do that unless you need to. Okay.